Hello, welcome to your Breathe Easy education. My name is Sarah. I'm one of the respiratory therapists working in Breathe Easy in Red Deer. Today, we're going to be talking about all of the different respiratory diseases and living well with chronic lung disease. If you are working through an education binder in Red Deer, those are either blue or black. This corresponds with section 3 of your binder. There is an awareness exercise that we will be talking about at the end. So today we're going to be talking about lung anatomy, including breathing, the self-cleaning mechanism of the lungs. We'll talk about gas exchange. What does that mean? What's going on inside of your lungs? And we'll break down all the different chronic lung diseases, including all of the ones that we can take into this program, as well as some other ones: COPD, asthma, and restrictive lung disease. So really the goal at the end of this presentation is for you to have a better understanding of what your lung disease diagnosis is and what's happening in the lungs. And from there, we will build on that information, and you will be learning tools in order to manage and improve the symptoms in relation to your specific lung disease, okay? So breathing, how do we breathe? Well, basically, and really generally, air goes in as you breathe in and air goes out as you breathe out. Okay, so we'll break that down here in later slides. So here is a cross section of the path that air travels on the way from the outside air as we breathe it in all the way down to the very, very smallest parts of our airways. So as we can see, one here is the nose. It is recommended that we breathe through the nose because of three things. Number 2 here is the nasal turbinates, and that is where incoming air is heated, humidified, and filtered. So does that mean that we can't breathe through our mouth? Well, obviously we still can, and breathing through our mouth is a way for us to get the most volume of air in. So sometimes if we're exerting ourselves, we breathe through our mouth because the demand of our lungs to get that extra oxygen to our working muscles becomes higher. But it's important to know why we're supposed to breathe through our nose whenever possible. Obviously, there's other factors at play here. If you have sinus problems, deviated septum, chronic sinus congestion, obviously there will be reasons why some people can't or don't breathe through their nose, and that's okay, right? The important thing is that you're getting the air in, but whenever possible, just know that the nose has an additional purpose to heat, humidify, and filter that incoming air, okay? So as we go down the path here, 4 is actually the next number in order, so we're not necessarily going in order here, but that's okay. So at 4, number 4 is the larynx. So this is your voice box. This is where your vocal cords are located. And as we breathe out, our vocal cords open and close and vibrate together, producing sound. This is also the location where air takes the path down the trachea towards the lungs, and food and liquids go down the esophagus. So our body has a way of knowing what's what. Occasionally we get things down the wrong pipe, and that's not meant to happen, but sometimes it does depending on what's going on. But for the most part, our body knows air to the lungs, food and liquid to the stomach, okay? So after number 4, we get into the trachea. You can see in purple here the cartilaginous rings holding the trachea and supporting it open. All the way down at the bottom here, you can see the carina. That's the point at which the trachea breaks into the left and the right side. So going to the left and the right lung. Alrighty. And as we enter the left and right lung, as the air travels down, the airways get smaller and smaller and smaller, okay? So the bronchi here, these are the last airways that are supported with smooth muscle. These airways are really important as we move along in the education because there are certain medications that act specifically on that smooth muscle, okay? So, and the final path, the destination of that incoming air is the alveoli. We'll talk about the alveoli in later slides. You'll get to see a blown up cross section of what exactly that looks like and what's happening there. Okay, so this is the whole path that air travels on the way in. So, bronchoconstriction is, we'll talk about this in later slides as well, but basically what I want you to look at is the top picture here is a normal airway. You can see the smooth muscle around the airway. So this is a bronchial tube or a bronchial airway. And you can see the cell wall here, and the inside of the airway is nice and open and patent. Okay, so that's a normal airway. On the bottom here, you can see the smooth muscle constricting around the airways, making it smaller, as well as there is inflammation and some mucus production there, okay? So we will break down when exactly this happens in later slides. So gas exchange, what is gas exchange? Basically, this is when air enters the alveoli, oxygen transfers into the blood, and carbon dioxide transfers out of the blood. So all of our tissues, cells, and muscles are using oxygen, and then they produce carbon dioxide. So that is kind of the exhaust of our body, is the carbon dioxide. So that's what we breathe out primarily. So here's that cross section of the alveoli I was talking about. This is right here. So each alveoli is only one cell thick, and it's important to note that they look like a little cluster of grapes. Normal airways, alveoli, are the same size and shape. The total surface area for gas exchange in alveoli is very, very large, which is a good thing. So each alveoli is sitting next to a blood capillary, so that the transfer of oxygen and carbon dioxide is happening all the time. And we breathe about once every second. So this gas exchange is occurring all the time, right? So we need to feed our muscles, feed our cells with fresh oxygen. All right, let's get into some of the diseases. So COPD stands for chronic obstructive pulmonary disease. This is actually a blanket statement that encompasses 3+1 lung diseases. So if your doctor or specialist says that you have COPD, your next question should be, okay, what type? And we'll learn here why that's important, because the individual management of each type of COPD is quite different. And it's important to note as well that you can have more than one overlapping obstructive, and we'll learn about restrictive here in a little bit. So you can have more than one thing going on. So chronic bronchitis and emphysema are two of the obstructive pulmonary diseases we'll talk about, and we'll break those down here in the coming slides. The main cause of COPD, if you guessed smoking, you are correct. Smoking is the main cause of COPD, but is not the only cause of COPD. Basically, breathing in any type of irritant, chemical, dust over time can cause that same damage in the small airways as smoking, which can develop into a chronic condition or COPD. Okay? So this is a very busy slide, but I'll break it down for you. Basically, the point of showing you this chart is that to reiterate that it's never too late to quit smoking, okay? So on the left here, we have your lung function, your FEV1. This is the amount of air you can get out in 1 second over your age. Okay, so the black line here is if you never smoked or you're not susceptible to smoke, no exposure to smoke in your life. As we age, our organs and our bodies age too, right? So all of our organ function will deteriorate over time. That's why eventually we will need glasses, hearing aids, all of those types of things. So that's happening with the lungs as well. The red line here is what happens if you smoke. So you can see a smoker, as they age, their lung function declines much more rapidly because of the damage that you are doing to your lungs, okay? Just gonna have a sip of water. So the dotted lines show what happens to your lung function decline if you quit smoking. So the first one is if you stopped at 45. So notice how the rate of lung function decline is now the same, but there's a little bit of damage. Okay? And same at 65. You slow the rate of lung function decline if you quit at 65, but there's quite a significant amount of damage. Okay, so it's never too late to quit smoking with the goal of slowing the progression of your lung disease and preserving the lung function you have left. Our lungs do not regenerate, so any damage that occurs in the lungs is permanent, but what we can do is preserve the function we have left and take necessary steps and learn tools in order to manage our symptoms so that we feel better. Okay? Bronchitis. So it's important to note that you can have a bout of bronchitis without it developing into a chronic condition. But the definition of chronic bronchitis is a consistent chronic cough for 3 months for 2 years. Okay, so basically with bronchitis, your airways become inflamed, you have an increased production of thick mucus, your body will trigger cough to get rid of that mucus, and this leads to airway obstruction. So chronic obstructive pulmonary disease, there is something obstructing the airway. So the trouble with all the COPDs is getting the air out, okay? This leads to trapped air. Hang on, I have to plug my computer in. Okay, computer's plugged in, we're good to go. So because of the presence of mucus that's sitting in the airway, it traps air in the airway and that air cannot get out again, okay? And it's that trapped air, that old air that's not participating in gas exchange that leads to that feeling of shortness of breath. So here is a different view of a normal airway. You can see the smooth muscle around the airway is nice and relaxed. The inside of the airway is nice and patent, and you can see the airway wall here. With a chronic bronchitis picture, the smooth muscle is restricted around the airway. You can see the inflammation on the inside and the production of mucus. Note here that it's kind of a yellowy green color. Everybody's a little bit different, but typically what we see with chronic bronchitis is a yellowy green phlegm. That's a normal part of your everyday, okay? So mucus removal becomes very, very important if you have chronic bronchitis. Whenever phlegm is sitting in the airway, it can, it's the last ditch filter. Anything that gets past the filters in our nasal turbinates must get caught in that phlegm. So that includes viruses, bacteria, dusts, other inhalants. And if mucus sits in the airways and you're not able to cough it all out, those bugs can start to grow. So you are at a risk of recurrent chest infections. Okay, so that's bronchitis. Emphysema. So typically, whenever your doctor or specialist says that you have COPD, they're most likely talking about emphysema. Some healthcare specialists use that term synonymously, but it's important that we double check, right? So basically what you have with emphysema is the alveoli, those smallest airways, 1 cell thick, become damaged or destroyed. And this is because of inhaling irritants, whether that's cigarette smoke, occupational exposure like welders, anything like that over time. This leads to a loss of elasticity. So when we're talking about elasticity in our lungs, we're talking about the ability of all of our airways to expand as we breathe in and go back to their regular shape as we breathe out. There's always air left in our lungs to hold their shape. This is called residual volume. If our lungs completely emptied and the airways snapped closed, the amount of force it would take to open millions of alveoli would be greater than we would be able to produce. So because of that, our airways always have a little bit of air in them so that they can inflate and deflate almost effortlessly. And that is why breathing occurs, whether or not we're thinking about it, almost effortlessly. So because you have a loss of elasticity with emphysema, you have bigger, floppier airways. Think about this like a balloon that's been inflated way too many times. And now there's a lot of, it's kind of big and floppy, and there's air that's trapped inside. That's essentially what's happening in your lungs. So the presence of old air and the inability to get all of that old air out leads to obstruction of new air coming in. Okay, so different than chronic bronchitis, where the problem is primarily mucus in the airways that obstructs the airways. Here it's old air. Okay, and that is what's called air trapping. When we talk about breathing techniques, there is a breathing technique called pursed-lip breathing that specifically reduces and treats air trapping with emphysema. Okay. This leads to impaired gas exchange. Old air is not rich in oxygen. So old air is higher in carbon dioxide. We don't want that sitting around in the lungs, right? Because then the new air delivering fresh oxygen to our bloodstream can't get in. And that's why you feel short of breath. Well, one of the reasons anyway. So here's that normal cross section of the alveoli, uniformly shaped grape clusters, okay? On the right, here is that COPD picture. So you can see how all of those little grape clusters have formed together to make one floppy airway. So there's a couple things to note here. As I mentioned, old air is going to be trapped inside that airway, so new air can't participate in gas exchange. And also, there is less total surface area in this big floppy airway for gas exchange in the first place, compared to all of the surface area in these uniformly shaped alveolar grape clusters. Okay? So that is the emphysema picture. Alpha-1 antitrypsin deficiency. It's important to note this quickly because there is one way you can get COPD without breathing in things that damage our lungs over time. Alpha-1 antitrypsin deficiency is the lack of a protein that's in the blood that protects the lungs and the liver, and that's the alpha-1 antitrypsin protein. So people that are born without this protein are at risk of developing lung damage and liver damage over time. There's a genetic component to this disease, meaning it runs in families. I've seen whole families have alpha-1 antitrypsin. So typically, before I change slides here, typically this will start to show up in the 20s. People will complain of shortness of breath, and usually it's tested because of their age. So COPD is usually diagnosed and symptoms pop up later in life, but anybody in their 20s that's showing up looking like a COPD, they automatically get tested for alpha-1 antitrypsin. And the only treatment for this is lung transplant. So depending on risks, benefits, that's a big undertaking. A lot of these people will end up on the transplant list. Okay, asthma. So asthma is a little bit different in how it presents, in that the lungs are normal. Your lung function is normal until you're exposed to something you're sensitive to. We call this a trigger. So dust, pollen, or smoke are three examples of things that asthmatics can be sensitive to. Stress and exercise can also bring on asthma symptoms. So basically what happens is when you're exposed to these triggers, you have what's called bronchospasm, meaning like a wheezy sounding cough. And basically the bronchial tubes they're in spasm, so the muscle is going crazy, and that's what causes you to cough uncontrollably. You also have an inflammatory response. So your body gets triggered into an allergic response that includes inflammation in the lungs, okay? And the secondary effect of that inflammation is increased mucus. So the idea is, let's increase the mucus production to trap all of that trigger so that we can get over feeling this way. But this is not a good place to be, not a comfortable place to be. And sometimes it can take a while to get over this effect, okay? So on the top here, we have the normal airway picture. We've seen this one before. And then this is what we were talking about with that bronchoconstriction. So the smooth muscle around the airways is very tight and constricted, narrowing the airway. You have inflammation on the inside of the airway, narrowing it even further. And you have that mucus production. Note here that the mucus is white. Typical normal mucus production for asthmatics is clear to white. And remember, with that chronic bronchitis, it was that yellowy green, okay? So not always, there's always exceptions to the rule, but typically that's what we'd see, okay? So bronchiectasis, it's important to note this one as well because it is included in the COPD blanket. It's because of recurring infections and inflammation, and what we see is enlargement of the mid-sized bronchial tubes, destruction of elastic tissue, muscle, and cartilage, and increased mucus leading to further infections. So when we're saying increased mucus, people with bronchiectasis have a ton. Every time they cough, they're bringing stuff up. It tends to be quite colored, so whether that's a yellowy green, kind of browny black, reddy. I've seen all colors be normal for somebody with bronchiectasis here. So lots and lots of mucus. So the goal really is to keep that mucus moving, effective coughing techniques, which we'll learn, and other things. So this, the same way that chronic bronchitis does, leads to obstruction of airflow because you have all this mucus sitting in the airways, right? So here's that picture. So again, a different cross-section of the airway, but you can see on the left, the normal bronchus or bronchial tube, you have the airway wall, and you have the inside of the airways nice and patent. So it's important to note here the mucus layer. So everybody has a mucus layer, whether or not you have a lung disease. And the purpose of that is to, like I said, the last ditch filter, catch anything that the nasal turbinates might have missed. And then the cilia here, they are little hairs that sit in the mucus layer, and they flagellate or wave back and forth to move mucus. Okay, so their job is specifically to move mucus up until the body triggers a cough to remove the mucus. Okay, what happens to cilia when you smoke a cigarette? It gets paralyzed for 1 hour. So every cigarette you smoke, the cilia is not able to move for about an hour. So if you're smoking a pack or more, your cilia is really not moving all day. So this is one of the reasons why smokers wake up and have a smoker's cough, because in the night when they're not smoking, their cilia comes back to life, and boy, it's got a big job to do, right? So that's one of the reasons why you have a productive morning cough. So on the right here, the bronchiectasis picture, you can see increased mucus. That mucus layer is really thick. And you also see destruction of the cell wall. So this includes destruction of cilia. So not only do you have more mucus, but you have less cilia to move the mucus. So stuff really sits in there, and your risk of infection is much higher, okay? So that's bronchiectasis. So that was obstructive lung diseases. So remember, obstruction, whether that's floppy airways or presence of mucus, leading to a problem getting the air out, okay? With restrictive lung diseases, the problem is getting the air in. There are two classes of restrictive lung diseases. There's intrapulmonary or inside the lungs, and there's extrapulmonary or outside the lungs. Intrapulmonary includes things like interstitial lung disease, pulmonary fibrosis, sarcoidosis, asbestosis, scleroderma, interstitial pneumonias, and pneumonitis. Outside the lungs includes kyphosis, scoliosis. Those are curvatures of the spine. Kyphosis is a hunchback, and scoliosis is an S shape of the spine. And those both impinge on your lungs' ability to expand, normally with a breath in. Severe obesity. So a lot of extra tissue pushing in on the lungs makes it harder for your lungs to inflate. So people that are very, very obese on chest x-ray, sometimes their lungs look smaller because their lungs can't inflate against the pressure of all that extra tissue. Diaphragm paralysis. When we talk about breathing techniques, we'll learn that the diaphragm is located right about here. It separates our lungs from our abdominal contents. And the purpose of the diaphragm is to initiate the breath. The diaphragm moves down to allow our lungs to fill. When your diaphragm is paralyzed, so there's actually two halves. You can have hemidiaphragm paralysis, meaning one side doesn't move. And you can have complete diaphragm paralysis, meaning both sides don't move. This can lead to problems with breathing. There is what's called a diaphragmatic pacer, which can help the diaphragm to move if you have complete paralysis. So let's break down some of these now. Interstitial lung disease. So what we're looking at here is a cross-section of the single cell layer of your alveoli. This is called the interstitium. Okay, so this is where oxygen transfers into the blood and carbon dioxide transfers back into the alveoli for that breath out. With interstitial lung disease, what we see is a scarring of the interstitium that's progressive over time. So your lungs are producing scar tissue, which makes the lungs more stiff. So it's tougher to take a breath in, especially on exertion. And as well, what we see is that scarring of the interstitium makes it harder for oxygen and carbon dioxide to transfer across. So this is impaired gas exchange. So a little bit different than with the obstructive diseases. It's an actual scarring that occurs. So air is able to get in and out, but it's not able to transfer in and out of the bloodstream. Okay. So that's interstitial lung disease. With pulmonary fibrosis, this is a progressive scar tissue that's formed in the lungs. It may be because of breathing in, if you were exposed to a mass amount of chemical that you breathed in, that can cause some scarring and permanent damage, or what's called idiopathic. So idiopathic pulmonary fibrosis, or IPF, is progressive scarring in the lungs, and we don't know why. Okay, so this can cause inflammation and or scarring. This can lead to stiffer lungs. So imagine your lungs like two really, really thick balloons. It takes more pressure to inflate those really thick balloons. If you have enough time, so if you have IPF or pulmonary fibrosis at rest, because you don't have an increased demand, you're able to inflate your lungs. You have enough time to breathe in. Sometimes you notice these people breathing a little more quickly, maybe a little more shallow, but generally they don't feel short of breath at rest. As soon as you get up to do anything, exert yourself, exercise, now we're having to draw in more air more quickly to feed the muscles. That's when you see problems. Your lungs can't inflate more quickly. So what we see is that your oxygen levels plummet quite quickly. Okay, so stiffer lungs, trouble getting that air in, oxygen levels will drop. So that is pulmonary fibrosis. So let's talk about extrapulmonary restrictive lung disease, or outside the lungs. So chest wall abnormalities, the two most common ones that I see are pectus excavatum, when your sternum protrudes in, and pectus carinatum, when your sternum points out. So again, these affect the lungs' ability to expand, which is why they're included in the restrictive lung diseases. Spinal abnormalities, we'll see pictures of kyphosis and scoliosis here in just a second. Severe obesity we talked about. diaphragm paralysis we talked about. Here's that scoliotic spine. It doesn't look too prominent here, but you can see that they're kind of just shifted off to one side. So it will affect your lungs' ability to inflate. And then kyphosis, same thing. Okay, so that was it for the obstructive and restrictive lung diseases. So definitely reach out to me if you have any questions about those. Hopefully you have a little bit of increased knowledge about what your lung diagnosis is. So let's talk about what symptoms you have. So everybody's lung disease looks a little bit different. Even if you have the same diagnosis with the same severity, how you present on a day-to-day and the things that you have to deal with are very individual, okay? So here's what some previous participants have said they deal with. Shortness of breath. So this might be doing certain activities. This might be at different times during the day. Cough with or without mucus. So not everybody with lung disease coughs, and not everybody who coughs has mucus. So it's important to note if your normal day-to-day lung disease symptoms include either of these things. And we want to get really specific with this. So if you cough, what time of the day do you typically cough? Is it worse in the morning? Is it worse in the evening? Is it worse when you drink your coffee? Is it worse when you lie down flat? Right? And if you have phlegm, is your phlegm worse at any time during the day? What color is it typically? How much is it typically? Is it thick? Is it thin? Is it foamy? Do you have trouble coughing it out? Do you use a mucus removal device like an aerobica or anything? Okay, so the more specific we can get about what's normal, then we'll talk about in a second here why that's important. So chest tightness. So do you feel, everyone feels shortness of breath a little bit differently. So do you feel like someone's sitting on your chest like an elephant? Do you feel that lung squeeze from the inside? Do you hear that musical or audible sounding quality to your breath? That's called a wheeze. Yeah, wheezing. So wheezing is actually the musical sound that's produced when that smooth muscle restricts around the airways. Not everybody has that. Fatigue. So what are your normal energy levels? What are you typically able to get done in a day? And anxiety. So we'll talk about in a coming presentation the importance of recognizing that anxiety and our breathing are very closely linked. Okay, so if you're working through a binder, in section 3 of your binder, there's a sheet of paper that says, let's talk about your lung disease symptoms. So on the top, list the symptoms of your lung disease that you experience most often. So this is normal stuff for you every day. You know, I typically have a morning cough with whitish yellow phlegm, and I usually cough it out in about a minute. And I'm usually short of breath, getting undressed before I hop in bed in the evening. Something like that, okay? The more specific you can get with this, we'll be building on this information when we talk about developing our breathing action plan. So it's really important that you know what's normal, so you know as soon as something changes. If you normally have a little bit of white phlegm in the morning and all of a sudden you have a ton of like yellowy, that's a change. And we want to make note of that. And we will learn in a later presentation what specifically you're watching for and how long you will accept those changes before we can assume that it's a chest infection. And you'll also learn what action to take. Okay, so this isn't a requirement for graduation, but we will build on this information. So do your best to list those lung disease symptoms that you typically experience, and let me know if you have any questions about that, okay? So to summarize, today we talked about lung function. We learned that the diaphragm moves the air in and out of your lungs. The lungs provide oxygen and remove carbon dioxide, that's gas exchange. Mucus captures pollutants and cilia sweeps the mucus up and out to prevent infections. And some lung diseases can interfere with these processes. So during this program, you will learn tools, tips, and tricks in order to manage your symptoms. And you will also learn what to watch for early detection of a chest infection or pneumonia, And again, the goal always is to preserve the lung function you have left and to slow the progression of your lung disease. All right, so list those symptoms of lung disease, and underneath, not to worry if you don't really know any strategies in order to reduce or improve your symptoms. That's why you're here. You'll be learning those throughout the program, okay? And that is all for today.